Hello everyone. This is my first day I do staff at the hospital. Today I will talk about pituitary adenoma. Pituitary adenoma are primary local endocrine tumors that occur in the pituitary gland and are one of the most common intracranial tumors. They account for about 10% of intracranial tumor and 30 to 50% of all pituitary tumor. Pituitary macroadenoma are twice as common as microadenoma. Anatomy: pituitary gland is located cellular function include two lobes, anterior, posterior, and one pituitary stalk around optic chiasm and below third ventricular and capillary sinus and pharynx sinus and cleavus. On the right, we can see sagittal T1 anterior lobe and posterior lobe and spark pituitary and optic chiasm on pharynx sinus and cleavus and mammillary body. Pituitary gland size: children less than 12 years, about 6 millimeter, and puberty about 10 millimeter. Răng do male about 8 millimeter and female and 9 millimeter, and pregnancy 12 millimeter, and also that more than 50 years gradually decrease in size. This image is a hypertrophy in pituitary gland during pregnancy. Critical endocrine and increased secretion and decrease and secretion and temporary visual and intracranial hypertension, vomiting and nausea and headache. Location of pituitary adenoma. Pituitary adenoma most commonly present an intracellular tumor. Rarely, pituitary adenoma may be seen in extracellular ectopic location. It may be also found in supracellular region, capillary sinus and paracellular region and cleavage and nasal cavity and nasopharynx and temporal bone and ventricular. This image we can see T1 and CT cyto. The soft map, tissue map, is located in cleavage and posterior floor of cellar with extension into the pharyngeal sinus. Procon embry, T1 cyto and chrolo and T2 chrolo DLAP-UI and T2 axial on school. T1 gado or dynamic with macroadenoma, and they have those morphometric microadenoma size less than 10 millimeter, macroadenoma size more than 10 millimeter, gene adenomas more than 40 millimeter, hormone imbalance, secretion 65%, proactin 15%, the about 10%, ICT as 6%, cursing. It had 1% mixed logically about 35%, usually macroadenoma, visual symptom of vacation. Microadenoma less than 10 millimeter and diameter, located on one side of the arterial lobe. It has a scope to produce symptoms due to mass effect. They are most often diagnosed as a result of a hormonal imbalance. Rarely they can incidental finding. On MRI, T1 usually is so intense and T2 hyper intense, and T1 dynamic see a broad reason of delay enhancement compared to the rest of the grand delay image are variable ranging from hyper enhancement. Most common is to iso-intent in the rest of the grand to hyper-intent. This case, we can see iso-intent in T1 and T2. Post-contact, we can see the lesion the delay enhancement to the rest of the gland. This case, we can see the lesion hyper-intent in T2, iso-intent in T1. Post-contact, the lesion is delay enhancement to the rest of the gland. Different diagnosis microadenoma with vascular cyst. It no enhancement of the cyst. However, a thin enhancing rim of surrounding. The image we can see the lesion hypointent in T1, hyperintent in T2, cyst. Post-contact, no enhancement. Normal pituitary gland, hypertrophy within pituitary gland with pregnancy and puberty, usually hyperintent on T1 due to rich lipoprotein. This case, we can see pituitary hypertrophy, post-contact enhancement homogeneous like Fuji mountain. Three diagnosis diaphragm cellular melangioma. We can see around region of faster enhancement compared to the rest of the gland. This image, we can see the lesion iso-intent in T2 and T1. Post-contact, we can see the lesion faster enhancement compared to the rest of the gland. Macroadenoma. It It is the most common pituitary tumor in adult. Diameter more than 10 millimeter. Signal can depending on tumor component such as hemorrhage, transformation, or necrosis. Patients typically present with symptoms of local map effect on nervation structure, especially optic chiasm. Some may present due to hormonal imbalance. They often invade the capillary silo, and the more it encircles the ICA, compressing vision and for third ventricular. They are soft tumors. They usually indent at the diaphragm cell, giving them a Solomon shape. Pre-check invasion based on imaging is important before surgery. On MRI, T182 typically is so intent to gray matter with laser lesion. The often heterogeneous due to hemorrhage, transformation, and necrosis. Star and FWI useful detecting with hemorrhage and calcification. T1 Garo solid complex moderate to broad enhancement. This case we can see the lesion located cellular and paracellular iso-intent in T2 at T1 and hyper-intent in T2 post-contact lesion enhancement homogeneous. The lesion compressed optic chiasm and partial encasement ICA. Invade the capillary silo. Color classification user 39 medial tangent and intercarotid 9 and natural tangent grade 0 medial 2 medial tangent grade 1 tumor tend to space between the medial tangent and intercarotid 9. Grade 2 tumor tend to space between the intercarotid 9 and natural tangent. Grade 3 tumor tend natural tangent. But they now compress enhancement ICA. Grade 4 the lesion complete and encasement intracapillary ICA. Image A, we can see the lesion tend to space between the medial tangent and intercarotid 9. Picture B, we can see a tumor tend natural tangent, but it doesn't envelope complete ICA. Picture C, we can see the lesion complete encasement ICA. Invasion assessment adjacent structure, optic chiasm, optic level, coronal and sagittal pituitary stuck salto T1 gado. The fellow is silent for third ventricular sagittal and coral. Vascular involvement coral T1 gado, ICA, M1 of MCA, A1 of ACA, and BA. We can see this image. We can see the lesion cellular and paracellular isointent ED2, hyperintent ED2, enhancement homogeneous and post contact. The map compress object chiasm and for third ventricular and partial encasement ICA. Different diagnosis melangioma and macroadenoma. Narrow diameter ICA and not narrow in diameter ICA. Melangioma enhancement rest. Macroadenoma poor enhancement compared to gland proximal. In case of bond, no enhancement bond. Epidural tile, macroadenoma no dural tile. To a picture, we can see the lesion homogeneous enhancement and dural title. The lesion complete encasement ICA. Scat melangioma. Differential macroadenoma with craniopharyngioma located in cellular macrocellular craniopharyngioma thì supracellular 75% and intracellular 35%. Don't see normal pituitary and can normal or compressed pituitary, homogeneous and heterogeneous, and considering the breast craniopharyngioma thì tip Adam tumor 19% calcification and cyst and enhancement medium enhancement craniopharyngioma solid grade enhancement. This case we can see the lesion located in supracellular and pituitary normal, and the lesion enhancement rate complication. The tumor can lateral tumor and with bleeding. Pituitary apoplexy due to hemorrhage of pituitary gland, intracranial hypertension, and visual defect and cognitive disorder. This image we can see lesion and cellular and paracellular hyper intent in the one scat it is believed post contact we can see the lesion enhancement heterogeneous before because central low enhancing earlier suggesting neurosis. Treatment patients with pituitary tumor need to be identified early for effective treatment for prostate tumor, and initial treatment is usually dopamine. For the other pituitary adenoma, immunotherapy is usually surgery with medical therapy being reserved for through though not by surgery. Intra-detection for patients whose tumor hormonal never or both the not controlled by surgery and mere treatment. Conclusion: pituitary adenoma as one of the most common cellular and paracellular region tumor. Microadenoma size less than 10 millimeter and macroadenoma size more than 10 millimeter. Template via visual and intracranial hypertension. Macroadenoma often invades the capillary silo, and the more it encircles the ICA, compressing vision and floor ventricular. Predict invasion based on imaging is important before surgery. My presentation and here. Would you any question for me?
Thank you, Lee. This is your first talk in English and as well in staff, right? And I find that I realize that your talk is very clear with all the information concerning the pituitary adenoma, such as the clinical symptom, the imaging feature, differential diagnosis, treatment, and as well as the treatment. And like Lee has mentioned in his talk, my pituitary adenoma is divided into two categories: the microadenoma and the macroadenoma. And when you describe an adenoma, a pituitary adenoma, you have to mention whether it is microadenoma or macroadenoma, based just simply based on the size of the tumor. The microadenoma is under the 10 mm, and the macroadenoma is over 10 mm. It's quite simple, right? And I think that's the second thing you have to pay attention on when you describe an adenoma, and particularly the macroadenoma is the invasive characteristic, because in this area, in the pituitary region, there are numerous anatomical structure, including the nerve, the arteries, the bone, many things at just at a very tiny area. So the invasive characteristic is very important for the surgeon to plan their surgery is very important. And sometimes it's more important than the nature of the tumor, um, and beside the conclusion of the nature of the tumor, the invasive characteristic, of course you have to distinguish between the adenoma and the other kind, the other common tumor at this area, such as craniopharyngioma, for example, and as well as meningioma, based on the imaging characteristic that Lee has mentioned in his talk. And okay.
Thank you.
Yeah, and do you have any question for speaker? I think this topic is a basic one, but if you have any question, I can I and Lee will give you some idea, the answer. Okay. If you don't have any question or comment, we can move on to clinical case practice, and you can find the playlist on the chat. Yeah.
That the clear one I invite Hằng Nguyễn.
Okay.
Yeah. Why is always Hằng?
I shall
I find out that Hằng is a popular sorry.
You share screen.
Yeah, yes. The first day, male, 60 years old, presentation with headache and recent weight gain. This is MRI patient. I see the lesion located intracellular and supracellular. The lesion has a hyperintense on T1. Hyperintense on T2. Post-contrast, the lesion has poor enhancement here. The lesion have well-defined margin. on coronal, I see the lesion extend to medial line. This means the lesion in the cavernous sinus, grade 1. Not in the bone. In summary, I think the lesion is the lesion has more than 10 mm. In summary, I think the lesion is macroadenoma with in the cavernous sinus grade 1.
No.
No. Why?
We you can see
Sorry, I give
T1 for contact and T1
for contrast. Here. I give you remote control.
Hello, Hằng Nguyễn.
Yes.
You turn off screen, share screen.
Okay.
We can see the lesion and cellular isointent in T2, T1 and T2. The lesion no enhancement, no enhancement.
Oh, no enhancement, not
No.
poor enhancement.
No.
Okay.
No.
Yes.
I think it is rat cyst.
Rat cyst. What does this mean? Rat cyst.
Rat cyst.
Not in the cavernous sinus. Italy. Not in the cavernous sinus. Not right. Yes.
No, sorry, I can see solid pituitary gland enhancement, the lesion enhancement that I think the macroadenoma. grade 1.
In the cavernous sinus grade 1?
Grade 1.
Yes, I think so.
I'm sorry, but why is like the poor enhancement on post gadolinium?
Of contrast.
And in the literature that you say that is it's a kind of enhancement post constructs. Yeah, first of all, it's not like not assist because it's not a high like the enhancement the hyper enhanced on T2, but I wonder if it's not enhancement after injection the gadolinium. But we should think about the microadenoma.
That
It's not typically match feature.
I invited home this time.
I
Okay.
think
So,
the lesion.
so this one is macroadenoma, right? Lily.
That
Yeah. So what are you discussing on?
But I have a question. Why that when in a theory that a microadenoma that it's post contrast it's got the bright enhancement, but here in the case we see that it's the poor even low intense after post gadolinium, and it's still keep thinking of the macroadenoma or there's something else.
I think the lesion enhancement, but heterogeneous.
Okay, so let me share my screen first. So in this case, you know, we have a mass at the anterior lobe of anterior lobe of and is located in the right side, right? And it touch the medial wall of the right cavernous sinus, and there is no, I think that there is no invasion of the carotid internal carotid artery. And you can see and you can notice that the tumor is hypo intense on T1 as well as hypo intense on T2. So my enhancement on the post contrast is not, it doesn't it is not no enhancement, it is my enhancement. And in this case is the hypo intense on T2, and on I think on the post contrast the mass, so the least enhancement than the normal pituitary tissue, right? Normal you can see that it is a typical finding of an adenoma. So an adenoma is often so the least enhancement than normal pituitary gland tissue. Yeah, and in this case, this is the typical location of macroadenoma, I think, a typical case of macroadenoma. And you can not say you can say that it is this what this one is a rat clepsis, because you know it's not a cyst, it's so enhancement, and furthermore this is not the location of rat clepsis. The rat clepsis located at the between the anterior lobe and the posterior lobe of the pituitary gland. Okay.
Okay, thank you.
And we want to do the second case.
Second guy.
And
Yeah, yes, but the first time I don't know how to share my screen.
because you have never attend our staff before, right?
Oh, that you don't call me. That's all.
So it my mistake. I'm sorry that I forgot to call you. We do it every day, right? From the first time you come here. Not this is not the first time we do the stuff in the hospital. Remember?
Can you see my screen? Hello.
Yes. Yeah. Yes.
Yeah.
Okay.
Choose
This
case. Okay. Nice.
Wow.
Bye bye.
Okay. This is the case of a 50-year-old female. The presentation of a galactorrhea. Okay. Keep into the images here. So we can see here a lesion situate in intracellular with the pretty round shape, clear margins with not my heterogeneous signal on T1, not pretty clear, but we can see here inside the pituitary gland on postgadolinium on coronal plane right here. This lesion, it's I may think it's a small lesion, maybe less than 10 millimeter. So I've been thinking about the microadenoma, not microadenoma. What else? That's all the images, Lee.
Yes.
Or I have to turn to the 3, or just stop here.
Yes. Pituitary function of the patient avenulated protein never, and other with normal pituitary function.
Well, I see the presentation of the patient is galactorrhea. Does that mean the breast secretes milk? Maybe, I think so.
elevated
So-
protein.
Yeah.
Protein.
So yes, and we see clearly here, and in the post contrast that the lesion, it's like got a little bit of uh, hyper intense that might enhancement. So I might think about the microadenoma.
That's I think it is macroadenoma.
Yeah. Okay.
Yeah, this case show a typical, you know, appearance of microadenoma, and as I mentioned on as I have mentioned, when you work with an adenoma, you should, you know, you should, you know, figure out whether it is a microadenoma or macroadenoma. Even though before, you know, before injection, you know, because it's very important. It's very important. When you have to evaluate the appearance of the tumor on the pre-contrast sequences, because you know that in the injection technique is different between, you know, microadenoma and macroadenoma. Okay. And in case of microadenoma, we do the dynamic injection, dynamic enhancement, right? As a dynamic injection technique. And in case of macroadenoma, we do the normal injection technique. Okay. And in case if you do the normal, you know, the normal injection technique, in case of macroadenoma, we can, you know, misdiagnose the microadenoma. Okay. So when the patient come with the clinical diagnosis of you know, pituitary tumor, you should, you know, evaluate the size of the tumor on the pre-contrast sequences. If you don't clearly see the tumor on the pre-contrast sequences, on T2 chrono, on T1 sagittal, as the radiograph, the technician do the dynamic injection technique, and do the dynamic post contrast sequences. Okay. And if you see a huge, you know, a huge tumor more than, you know, 1 centimeter in diameter, for example, tumor, you don't have to do the dynamic sequences. You just, you know, do as usual. Okay. It's very important. And in this case, you that they do the dynamic sequences. Okay, dynamic post contrast sequences.
Yes.
Next case, please.
I invite Hải Nguyễn. Third case. Hải Nguyễn.
She's busy, I think. She's busy. She's busy.
I can do the case, but Dr. Hai can do. Let him do it.
Thank you.
But come,
No, you
do the
have
case.
to
Dr.
do the case.
Yeah.
Yep.
Her supervisor.
3.
Okay, we can invite, you know, Dr. Hai to do the third case, please.
Wow.
Can you have?
Okay. I'm going to share the screen. Just wait 1 minute.
Yes.
What happened?
Now you do this case.
We are doing the daily stuff, you know, and the topic today is a very simple pituitary adenoma. And so
Wow.
yeah, we as a pituitary adenoma, and you don't have to think a lot about giving the diagnosis. You just say, you know,
Pituitary.
pituitary adenoma.
Yes.
Yeah, so if you scale you have to control it. I have my freedom. It's the number
Yeah.
2 to use
You have
the
to
CT scan. Number 3 will look at. If it's too quick, you could use this one. This is slower. This is slower.
It's a typical case of pituitary adenoma. Now don't click for number 3. Promise.
Just use this one. This one is slower. And look at the sequence on. Click on. Click on.
Okay.
Just click on it already here. Don't need to draw.
It seems like this is the first time he used, you know, radio. Yeah.
We don't have more image for this.
Slow.
Why you click on the number 4 all the time?
What is this?
Không phải là chỉ có bệnh nhân lương văn phong 6 tuổi không nhỉ? Ba, sao bảo người cứ gọi con số này? Sao không phải đến khoản chưa đến khoản? Ủa ba gì? Cổng từ. Đang hỏi bệnh nhân vợ phòng nhà mình không đã? Rồi đâu quên. Chưa có khoản. Gì à? Cái cuối cùng là hai cái tổn thương là 11, 12.
Pituitary adenoma.
Sao không xong?
So difficult.
Adenoma. It's not adenoma.
I think pituitary is normal.
Dr. Hai is really hands-on today.
Yeah.
Show your best.
Who the hell is talking? What?
I am.
Đó, thế mới bảo xóa cái cột sống thắt lưng, xóa lên cột sống.
Put your hand out of your nose.
Tổn thương mà. Mới bảo cho thừa xóa cái thắt lưng, xóa cả ngực. Xóa cả ngực rồi, không được nói nữa rồi.
Okay, Hưng, can you try the case?
You know, actually, I online by my cell phone, and it is so hard to control the mouse. Could you please help me? Anyone help me to control the mouse?
You don't have to control the mouse. I think you can, you know, make the diagnosis based on this slide.
Yeah, absolutely. And the first idea that appeared on my mind is that graciopharyngioma, and with the subtype of the papillary, it is usually appear with the older patients, and you know that the solid part of these lesions is overwhelming majority, right? And it is enhanced vividly after do the contrast. So I can jump straight.
Oh, I think it is a meningioma.
Meningioma, but I cannot see some features, some characteristic that that can rule out.
Think about the tumor at the occipital lesion.
occipital lesion such as glioma. But you know that glioma in hands is just mild.
On the axial on the occipital lobe, we have two different tumor here. So what kind of tumor are you talking about?
I'm talking about craniopharyngioma.
No, but take a look on the image. We have two
Posterior fossa.
two enhancing mass. One at the pituitary, yeah. One at the occipital region. And this.
Okay, I talk about the bigger. I talk about the bigger.
Okay, bigger one, the bigger one. Why you say that it is pituitary? Sorry, the
craniopharyngioma. Absolutely. First of all, it is located at the above of the cellar. Secondly, it is like the solid lesions and enhanced vividly with the age of the patients. And with the age of the patients, I can think about the patients have a subtype of the papillary craniopharyngioma.
Okay, and how about the adamantinous type of craniopharyngioma? What does it look like?
Adamantinous type, it just appear at the younger age of the patients, and with the characteristic of the lesions, including two parts, like solid part and cystic part, right? And it is like overwhelming majority of the cases, it appear with calcifications, but in this case, it's like really hard to see the calcification.
And the soft tissue content is is predominant in this case, right? Okay, and we have a supracellular lesion in an adult, right? With the soft tissue mass and with some cystic small cystic lesion at the peripheral and the soft tissue so strong enhancement. It is quite typical of papillary craniopharyngioma. Okay, so what do you think, Lee?
Yes, I think craniopharyngioma, but tumor occipital rise, I think meningioma.
Okay, so we have two different kind of tumor in this case. We have the papillary craniopharyngioma at the supracellular lesion and a meningioma at the occipital lobe, right? At the occipital region.
Yes.
Okay. Do you have any comment or question for the cases as well as for the topic today? Okay, if you don't have any more question or comments, see you next week.
Yes.
Bye bye.
Thank you, teacher.
Bye, sir.
Goodbye.
Bye bye, Dr. Hải.